So the video was rather too big to upload to YouTube. This is the second part of the video on pituitary disease. Now, I'm of an age for this person's name to mean two things. It was very famously Peter Cushing, who was in the Star Wars first movie. But this relates to a famous surgeon, if I can write this well, Harvey Cushing, who would have been operating in New England in 1910, 1915, those sort of times. And he was the father figure for transsphenoidal surgery, and he gives his name to a number of diseases. Well, Cushing's disease is very specific, and it isn't the same as Cushing's syndrome. Cushing's disease is about too much cortisol, or hypercorticolism, which is secondary to disease of the pituitary. So effectively what we're talking about is a pituitary tumour that makes too much ACTH, that in turn affects the adrenals and pushes up the level of cortisol. So excessive ACTH, overproduction of steroid, is what Cushing's disease is all about. This slide shows the many symptoms and physical signs that people with hypercorticolism will have, which you'll see in Cushing's disease. You'll also see it in Cushing's syndrome, which we will meet in the next lecture. The commonest signs and symptoms are shown at the top of the slide there. So people who have too much cortisol, so here I'm using the more generic name, Cushing syndrome, will have these features. So they'll have central adiposity, some wasting of their limbs, and that leads to proximal muscle weakness. And because of loss of collagen, they get thin skin and easy bruising, giving rise to the characteristic so-called abdominal striae, which, because of the absence of collagen, look rather purple in nature rather than the pale normal striae that many people may have. An increase in subcutaneous fat in key areas like the face and over areas of the back give rise to these other physical features as well. And here are some images of people who have Cushing's syndrome, and some of them will have Cushing's disease, no doubt. You see the abdominal striae on this person with central adiposity, and you get the impression of pretty thin limbs in this lady here. And then the other feature we talked about is the intrascapular fat pad that you see on this lady's back. Rather similar to what we talked about in acromegaly, the mainstay of treatment is going to be surgery. And the sort of tumours that people have in Cushing's disease tend to be somewhat smaller and are much more likely to be cured primarily by transsphenoidal surgery. In the past, before those techniques existed, sometimes the treatment was to remove both adrenal glands. So the concept was, if you couldn't get to the base of the brain and the sella turcica, it would be safer to remove both adrenals gland. Well, the younger the patient, the more serious the consequences could be. And there was an entity that got described, which was an aggressive growth of the pituitary and an invasive growth called Nelson syndrome. And what was going on there was that when you remove the adrenal glands, what you don't get is the negative feedback from corticosteroids at the level of the pituitary, so the pituitary can grow in a much less regulated way than it could before, and cause lots of local invasive symptoms. Occasionally we need to resort to radiotherapy, and if all else fails, there are drugs that can block the adrenal access, and here's one of those mentioned, the tyrapone. Sometimes pituitary tumours are just there and they do nothing else, so-called non-functioning pituitary tumours, and that would be about a third of all pituitary tumours. And here their symptoms are all down to space occupation, pretty typical symptoms that you get with that morning headaches, visual field defects. And then it might give rise to the absence of pituitary hormones, which we will talk about. Again, the mainstay of treatment is going to be surgery. Often you have to resort to using pituitary radiotherapy, and there are no other types of medical therapy that will work for this. So loss of pituitary function, or so-called hypopituitarism, could be congenital, but let's focus on acquired causes, which I would see in adults, my domain. This could be because of pituitary tumours, it could be iatrogenic because of surgery or radiotherapy. One special case of hypopituitarism used to be seen in pregnant women who lost blood at the time of delivery. The pituitary enlarges in size during pregnancy, and the catastrophic drop in blood pressure that could occur from hemorrhage sometimes led to pituitary infarction. And that would present with women being unable to breastfeed and losing weight and having all the features of hypopituitarism that would go along with that. In the past, it used to be uniformly fatal. So it's a dreadful thing, and we've known about this since, I think it was about the late 1940s that Sheehan described this, and gladly this can be dealt with very readily now. Pituitary apoplexy could be thought of as a kind of stroke. It's pituitary infarction occurring often from hemorrhage into the pituitary. You could think of it as a process very similar to subarachnoid hemorrhage in that case. And in fact, SAH, subarachnoid hemorrhage, is very much on its differential diagnosis.